Um, I will let everybody in and let you all hang out.
Hey, Robbie, thanks for doing that. If it quiets down again, just join us and we'll update you
Yeah,
and then, okay?
that sounds perfect, buddy.
All right, take care. Good luck. Elizabeth, tell us a little bit about yourself.
So I'm Elizabeth. I'm a third year medical student in Atlanta right now. I'm from Swanee, Georgia, so I've lived in the South my whole life. I'm interested in internal medicine, so when I had this patient on my IM rotation, the residents were like, "Oh, you should present the case. It's fun." So here I am. I'm excited.
And when did you choose internal medicine?
I think so. I worked as a nursing assistant before medical school and I loved like inpatient. I thought I wanted to be a hospitalist. And then after my IM rotation, I was like, I love this. So I'm all for it.
Well, thank you so much for joining us. Very excited to discuss the case and who is scribing today?
I am scribing today.
Oh,
Uh,
Mariana, thank you so much. Do you want to just say a few words?
Hello, everyone. Nice to be here with you. I'll be scribing today. I think Mario is doing teaching points today.
Great. Mario, can
Right.
you? Oh no,
Yes,
please keep going, Mariana. Sorry.
No, go ahead. I almost said that I'm ready to start.
Okay. Maria, do you want to just say a quick hi before we jump into it?
yes. Hi. Can I can turn my my camera right now, but excited to be here. And let's go.
Excellent. Well, it's nice to hear your voice. Why don't we get started, Elizabeth?
Sounds good.
By the
So
way, do you
uh,
prefer Elizabeth or Liz?
I do actually go by Elizabeth.
Elizabeth, perfect. Thank you.
But yeah, thanks for asking. So to start, I have the chief complaint, which is a 50-year-old woman who presented to the ED after a syncopal event. And I can dive straight into the HPI.
I think I can just make a quick teaching point here,
Yeah,
Elizabeth, is that the most important aspect of the HPI here is what preceded the syncope. Was the event actually witnessed? Like what happened during the event? And then what happened after the event? So the pre, the event, the post event. This is going to be super helpful because the patient, although is coming in with syncope, we're not quite sure just yet. It seems like they're coming in with transient loss of consciousness, which makes us often gravitate towards syncope or seizure and less likely low sugar. But understanding the pre-transient loss of consciousness symptoms and signs, the event and the post will allow us to put it in one or the other bucket, which really has consequences in how we shape our differential diagnosis. But please continue, Elizabeth.
yeah. So going into the HPI, notable history for her. She had a left MCA stroke 1 year prior to this event with baseline right upper extremity weakness and expressive aphasia. Um, when we discussed with her what happened, she stated that she was outside getting ice cream when she suddenly fell and lost consciousness. Um, it was witnessed as well. She did hit her head on the left side of her face and scratched her left arm. She reported feeling well at the time. She said she felt very hot beforehand, but denied dizziness, chest pain, palpitations, or shortness of breath at that time. She also denied nausea, vomiting, diarrhea, or other falls in the days leading up to this event. And she regained consciousness over a few seconds and was back to her baseline fairly quickly. She experienced no confusion or disorientation per her or witnesses of the event. Um, she did not have any loss of bowel or bladder, nor any tongue biting. Um, EMS did document that bystanders reported stroke-like symptoms. They were not specified. And then once she arrived to the emergency room, she was like alert at her baseline. And she said that her neurological deficits were at her baseline. And then she had never had a syncopal event in the past. And I'll add here, we did like a pretty thorough review of systems for her, and they were grossly negative, except for she did note that she had some foamy urine.
Interesting. First of all, a really good job with the presentation of the HPI. Like, there's not a single additional data point that I want from you because it's so thorough, and I think it paints an incredible picture. And for a second, we're gonna evaluate the problem of transient loss of consciousness without incorporating the past medical history of stroke. If you were just to acquire such an HPI, there are many reasons why you should prioritize syncope over seizure, because really these are the two that you want to try to tease out before considering less likely causes of transient loss of consciousness. What was really helpful here was the fact that the patient had no post-ictal confusion. So they had a sudden loss of consciousness, they woke up, and they were their normal self. This really makes seizure less likely and prioritizes syncope. There are other characteristics that you can use that can help you make progress in seizure versus syncope. On physical exam, tongue laceration is probably the most useful marker to point to seizure over syncope. There's other findings like urinary incontinence, but that I don't think is as good as finding lacerations on the side of the tongue. The one thing that you can't use necessarily, because remember, everything that we use is on a spectrum in terms of altering the post-test. Convulsions, more common in seizure, but you can certainly have post-syncope rhythmic shakes that mimic seizure. So in this case, we're having no convulsions. We'll see on exam if there's any tongue laceration, but I doubt there is. And there's no post-ictal confusion. So based on the data we have, we can be pretty confident that what we're dealing with here is syncope, but then the past medical history makes us pump the brake just slightly, because strokes can certainly cause transient loss of consciousness, not necessarily stroke. A better term for that is TIA. And they have to really be at the location of the brainstem that keeps us awake and alert, and then they have to disappear. So could this patient be having transient ischemic attacks? There was a recent New England Journal of Medicine CPC, which like blew my mind. But basically, this patient had really bad atherosclerotic disease and kept coming to the hospital with transient episodes of confusion. And it was a diagnosis I had never heard of, but you can get from this atherosclerosis, you just get transient embolic phenomena that resolve. And the treatment there is you got to actually go and clear up the atherosclerosis in the carotid artery. All that is to say, with the data that's been presented so far, very concerned for syncope, less concerned for seizure, and really being a little cautious with the past medical history of stroke. And anytime you have any kind of medical event with the background of stroke, you can have recrudescence of symptoms. So it wouldn't surprise me if she had syncope and they may have seen stroke-like symptoms that are really either a residual of her prior stroke or some form of recrudescence of that prior stroke. So the question then becomes, how do you approach syncope? And I'm going to share I'm going to share something very brief on that right now, but the exam is going to be really helpful. It comes down to the core, and I learned this from Stephanie Sherman, the core causes of syncope, C-O-R, core, cardiogenic, orthostatic, and neurogenic. And based on the beautiful HPI presented, we can make progress on which bucket we're likely in with the data that we have. You see, with the orthostatic causes, this doesn't sound like orthostatic hypotension. Those patients, generally, when they have an upright posture, their pressure drops, they decrease perfusion of the brain, they feel lightheaded, and then they might pass out. But that's key on history. It's going from a supine to upright. That's even more important than doing orthostatic hypotension vital signs, which hopefully we'll get on our physical exam. The R for reflex-mediated causes of syncope, these are really your neurogenic. These ones, there's often a prodromal symptoms. Here, the patient had some prodromes of just feeling a little warm. So you can't eliminate the possibility of a neurogenic cause of syncope. And the best way to think about this bucket is like people who see blood and just have a negative reaction to that. They may have a reflex-mediated syncope. And in this bucket, even in people who are shaving and they might stimulate the baroreceptors, that can lead to neurogenic syncope. But here, I am most concerned for a cardiogenic cause of syncope. And with the cardiogenic cause, you can just break down the heart into the pump and electrical activity. Pump and electrical activity. Usually, when it's due to a mechanical cause like aortic stenosis or pulmonary hypertension, there's other clues, like the patient's having dyspnea, lightheadedness. But if it happens like that, then you really got to be worried about an arrhythmogenic cause of syncope. So basically, we're going to get much more data, but based on what we have, I think syncope is more likely than seizure. I think that a cardiogenic cause is more likely than orthostatic. And within the cardiogenic, based on what's been presented, I'm most concerned for a rhythm, but our exam and more data is going to help us make progress. Back to you, Elizabeth.
Okay. So for past medical history, in addition to her stroke, she has a history of type 2 diabetes and hypertension. Her home meds on admission were amlodipine 10, losartan 50, glipizide 5, and Eliquis 5. She has no pertinent family history, and allergies to medications. She reported an allergy to amoxicillin that gave her hives. Going into her social history, so she had recently moved to Atlanta from North Carolina to be closer to her daughter. Prior to her stroke, she was a bus driver, but she had to quit her job and had been unemployed since then. She lives in Atlanta in an apartment with her new boyfriend. He is her only sexual partner within the last year, and they inconsistently use condoms. She reported no history of sexually transmitted infections and denied ever noticing any symptoms. She does report poor oral intake when talking about diet and exercise. She normally eats very small portions for her meals and does not drink much water or fluids throughout the day. She denies any alcohol use, but she does have a 20-year smoking history. She smokes 1 pack per week and denies any recreational drug use. And I can move into physical exam. That's cool. So her vitals on admission, blood pressure was 138/82. Temperature was 37.2 degrees Celsius with a heart rate of 89. And her respirations were 16. Normal. We did do orthostatics on her. She was negative. I couldn't find the exact values that we got, but she was reported to have negative orthostatics. So overall, on exam, she looked well. She was in no acute distress. Her extraocular movements were intact. She had no asymmetry on her pupils. They were equally reactive to light. She didn't have proptosis or orbital edema. She had an abrasion over her left eyebrow. She had no tongue lacerations. On cardiac exam, she was regular rate and rhythm. She did have a 2 out of 6 systolic murmur. It was appreciable throughout her precordium. She had no JVD. And on lung examination, she was cleared of auscultation bilaterally. We appreciated no crackles or wheezes. Abdominal exam was soft, non-tender, non-distended with normal active bowel sounds. Her extremities were warm and dry. She had an abrasion on her left forearm. And she did have trace pitting edema up to the level of her ankles. And then on neuro exam, she was alert and oriented ×4. She had a mild right side ptosis that when she looked in the mirror, she said, that looks like my normal face. Otherwise, no facial asymmetry. Her right upper extremity was a 3 out of 5 strength, and strength was 5 out of 5 elsewhere, and she had no sensory deficits.
Thank you, Elizabeth. Is it fair to say that her neuro exam is at baseline compared
Yes,
to
it was
prior?
at baseline.
Okay. Very, very helpful. This is great. If you saw what I did in the first aliquot, Elizabeth told us that the patient had foamy urine. I skipped over that data point because my mind was solving transient loss of consciousness, and it would be hard for me to connect that with proteinuria, so I didn't comment on it. Now, things may change based on the exam when we get the lower extremity edema. So we'll talk about the exam, but just quickly looking at the past medical history, this patient is on apixaban for the prior stroke, which may have been thought to be from AFib and embolic phenomenon. What this does for me is I have to get a CT scan to make sure that there is no bleeding in the brain after head trauma. The diabetes just makes me think, like, how bad is the diabetes in the A1C? Because neuropathy can lead to autonomic neuropathy, which can lead to orthostatic hypotension and then transient loss of consciousness. The fact that the orthostatic vital signs were negative and the history didn't really sound like she's going from supine to upright, I think it's less likely the case that we're dealing with orthostatic hypotension. So then we come to the physical exam, and you have to be cautious when you interpret this physical exam because we're literally examining the patient when she's normal. She came in with a complaint that was transiently abnormal, and we didn't evaluate her in that specific moment. Nevertheless, the exam is helpful. So the murmur jumps out, as abnormal. And when you have a murmur and you have syncope, you go into the structural cardiogenic causes of syncope. This includes aortic stenosis, but it would be odd to have aortic stenosis that's first diagnosed from an event of syncope. Not to say it's not possible, it's just less likely. Other causes of murmur and syncope could be hypertrophic cardiomyopathy. And this is where listening to the murmur and having the patient Valsalva might be helpful, because when they Valsalva, it increases the intensity of the murmur because you have less volume in the heart. And if you have less volume in the heart, the murmur is just worse based on the regurgitant flow. Pulmonary hypertension can lead to tricuspid regurgitation that can cause a murmur. Pulmonary hypertension can lead to right-sided heart failure that can present with lower extremity edema. But the lower extremity edema could just be true and completely unrelated. She's 50 years old. By the age of 50, half the population has some form of venous stasis. Some people manifest, others don't, meaning they have venous valvular insufficiency. So the lower extremity edema can just be venous stasis from venous valvular insufficiency and unrelated to the syncope that the patient came in with. Alternatively, because we were told that the urine is foamy and now we have edema, are we building up a case for the triad of nephrotic syndrome? So for me right now, problem number one is transient loss of consciousness in someone with a prior history of a stroke with a 2 out of 6 systolic murmur. And for this, we're going to need an echocardiogram. You don't need to get an echo in all patients. Like if this patient didn't have a murmur, I would not recommend an echocardiogram. But in this patient, you do want to get an echo and see what the structural apparatus is within the heart. you're going to want an EKG, but the EKG may not capture an abnormal rhythm that may have caused the syncope. So you're going to put the patient on tele. And I'm already thinking that this patient, if I don't find the cause, is going to need a Zio patch or a Holter. It's like a little sticker that goes on the chest that can monitor the rhythm for a 2-week period. So if she has another event, then we can actually capture what the rhythm was during another event. And for her, I would get urinalysis and a spot protein to creatinine ratio because of the foamy urine and the lower extremity edema. So CT scan, echocardiogram, we're going to get the basic labs, EKG, tele while I admit her, and get a UA to just see the degree of protein, but really think I'm going to get a spot protein to creatinine ratio because she does have diabetes. So I wouldn't be surprised if she has some albuminuria that makes that urine dipstick positive. But back to you, my friend, Elizabeth. Hopefully I haven't overlooked any of your clues so far.
Yeah, so I'll go ahead and give you the initial lab work that we did on chemistries. Her sodium was 131, potassium 3.4, chloride was 97, CO2 29, her BUN was 29, her creatinine was 2.1 from her baseline of 0.8. Her GFR was 28, glucose 140, her total serum protein was 5.7, and her albumin serum was 2.0. She had normal LFTs. Pretty benign CBC. She had a low hemoglobin of 9.5, and her hematocrit was 29. Normal white blood cells, normal platelets. On urinalysis, she did have what was notable was 3+ protein, 1+ glucose. So she had 6 to 10 white blood cells, 3 to 10 red blood cells. And then I'll go ahead and give you the protein creatinine ratio that we did came back as 24.5. With a total, like her total urine protein was 2,700. And then on urine microscopy, since that's fun, she had some white blood cell casts and some hyaline casts. And then I can give you the imaging as well that we did initially if you want.
Up to you, Elizabeth. Would you like me to share my thoughts with this, or do you want to give the imaging?
I'll go ahead and give the imaging. It's not super exciting.
Okay.
So we did do her EKG, showed sinus tachycardia. We did get a CTA head and neck. It showed no acute infarction or intracranial hemorrhage, just chronic decreased flow within her left hemisphere. We got an MRI as well, showed no acute intracranial abnormalities, but chronic encephalomalacia of the left MCA territory. And her echo showed concentric hypertrophy of her left ventricle with an ejection fraction of 60 to 65, which was unchanged from her echo that she got with her stroke.
All right. Well, let me just first say this. I don't think I've ever seen a spot protein to creatinine ratio of 24. The highest I've seen is 12. So this is really, really striking. And first, I'm going to talk about the less exciting stuff before we talk about the exciting stuff. The less exciting stuff, and you remember, in the order of tests that I really wanted that echocardiogram. And that hypertrophy that we're seeing is explained by the patient's background of hypertension and is not causing this patient's syncope. So that echo was so helpful. And we didn't find any obvious valvular disease on that echocardiogram. So then we go to before I talk about the spot protein to creatinine ratio, we go to the chemistry panel and we see that this patient has an elevated creatinine. And this elevated creatinine can be due to pre-renal, renal, or post-renal. I'm going to go on the limb and say that there is some pre-renal component to this, though I don't think it completely explains what's happening with this patient's creatinine, meaning I expect probably there's going to be some improvement with administration of fluid. But I can't stall anymore, Elizabeth. I actually have to talk about what matters here. And what matters here is the albumin and the degree of proteinuria. So in aliquot 1, when someone comes in with transient loss of consciousness, it would be a mistake for your mind to go to nephrotic syndrome. It would, Now we're going to see how we can link nephrotic syndrome to syncope. But before we do that, I have to emphasize there's no reason for anyone to ask, the foamy urine on aliquot 1. I bet you what happened. Well, I don't bet you. I'm curious to hear from Elizabeth. You get the data, and then you might go ask that specific question. But we'll find that out in a little bit. So let's talk about nephrotic syndrome for 2 or 3 minutes. Here's the important point. Nephrotic range proteinuria is different than nephrotic syndrome. A lot of patients with diabetes is probably the most common cause of nephrotic range proteinuria, but only a very minor fraction of patients with diabetes go on to form nephrotic syndrome. So what is the difference? The difference is, and by the way, I think I have a hypothesis as to why, and I'm curious to know if Tiago agrees, disagrees, or if he has any thoughts. Because why wouldn't someone that's losing so much protein in the urine not develop nephrotic syndrome? So what is nephrotic syndrome? It's not only nephrotic range proteinuria of more than 3.5 grams per day, but once you're peeing out all that albumin, you lose serum albumin. The liver just can't keep up. So your albumin is also less than 3. So she's met 2 of the 3 in the triad. The third part is the edema of the legs. So she has all 3 of the triad. So I'm confident to say this patient has nephrotic syndrome. This is not an end diagnosis. It's a proximal diagnosis, meaning we have to ask, why does this patient have nephrotic syndrome? And is the cause of the nephrotic syndrome also linking to why the patient's in the hospital? It's not because of edema of the leg or foamy urine. It's because she fell and hit her head. So we got to still be tracking the syncope. The reason I think a lot of patients with diabetes don't go on to develop nephrotic syndrome is I think the liver is able to match the output of albumin, because at the end of the day, if you lose a lot of albumin, but your liver compensates, your serum albumin won't go low and you won't develop nephrotic syndrome. But when you have other causes of nephrotic syndrome, which we'll discuss momentarily, oftentimes those release cytokines and it results in an inflammatory milieu that suppresses the liver. So you have 2 hits. You're losing albumin, and the liver is not as effective in keeping up with that albumin loss. Now, the question becomes, what are the complications of nephrotic syndrome before we talk about what can cause nephrotic syndrome? That's more important of a question here than what can cause it, because we haven't explained why the patient had syncope. When you lose all this albumin and protein in the urine, your body actually becomes hypercoagulable. It becomes hypercoagulable because of the balance between the loss of clotting factors and anti-clotting factors. Essentially, you lose more anti-clotting factors, and therefore you're at an increased tendency to clot. Now, here's the pearl for you. The lower the albumin is, the higher the risk of clotting. Especially when you get to less than 2, these patients are at significantly high risk of clotting. So in this patient, I actually would want to get a CT of the chest with contrast, specifically looking for a pulmonary embolus, because we know that 10% of patients with pulmonary embolus present with syncope. Other sequelae of nephrotic syndrome include losing immunoglobulin. So these patients are at risk of infections. And the types of infections are the ones that require immunoglobulins to opsonize bacteria that are then degraded in the reticuloendothelial system. So think of S. pneumo, for example. So these patients are at higher risk for pneumonia because they don't have immunoglobulins to opsonize. But in general, they are immunodeficient, primarily from a decrease in immunoglobulins. Hypercoagulable, immunoglobulin deficient, and these patients are hyperlipidemic. Something about this losing of protein causes the liver to increase lipid production in the form of VD, LDL, and all that stuff. That I leave to Tiago to comment on in the chat. So far, of the sequelae of nephrotic syndrome, which you should have to be aware of, immunodeficiency, hyperlipidemia, hypercoagulability. Only of these 3, the hypercoagulability can explain the transient loss of consciousness. So I would get lower extremity ultrasounds, and I would do a CT scan of the chest with the PE protocol. But then the question becomes, why is the patient having nephrotic syndrome? And if we answer why they're having it, could that potentially be affecting and causing the syncope? So it's either through the consequence of nephrotic syndrome or the driver of nephrotic syndrome that my mind is trying to make a link. And this is where it gets fun and difficult. Fun and difficult. And I'm going to teach you a way to remember the various causes so that hopefully it'll be okay for you. And I think my brother just came back online. And Robbie, are you at a space to talk? Unmute. We have to practice this, man. I want to throw the ball to you.
Rez, I've been roaming around, but I've been catching glimpses here and there, and I just heard you say my name.
So are you in a space to talk for 2 minutes to try something?
Yeah, definitely. What are we talking about, Prof. Rez?
So Robbie, we have a patient, 50-year-old woman, transient loss of consciousness,
Okay.
likely syncope for sure, had foamy urine. The albumin is 2, nephrotic range proteinuria, lower extremity edema, has nephrotic syndrome. I said, I'm trying to explain this through this consequence of nephrotic syndrome, like hypercoagulability, or the cause of nephrotic syndrome. So I was just about to talk about causes of nephrotic syndrome, which I pass the mic to you.
Oh my gosh. Wow. What an honor. What an alley-oop to Prof. Rez. I've been listening to you guys chat, and I feel like when you're ooh, I gotta go. Sorry. Yeah, sorry.
I knew Robbie couldn't do it in 2 minutes. So let me mute him. Okay, good. So guys, so the nephrotic syndrome, the way to think about it so that you never forget is that it's either a primary etiology for nephrotic syndrome, meaning that there's no secondary cause, or it's acquired. This is like many things in medicine, primary or acquired. And the question becomes like, do you have to biopsy every patient with nephrotic syndrome? No, you don't. How crazy is that? Is this blasphemy? No. There's one population that you don't need to biopsy. Probably you don't need a biopsy. And those are the population that has the phospholipase A2 receptor antibody positivity of membranous nephropathy. This population you don't need to biopsy because that in itself is a very strong clue, and you know the etiology. And so you know what the treatment options are going to be for it. Otherwise, in the vast majority, you do have to biopsy, and it often helps to biopsy first and then send tests later. But what you'll see is that the nephrology team is going to be like, send Hep C, send Hep B, send HIV, send syphilis, send complement, send ANA. But that's not, I understand all that. But at the end of the day, if the phospholipase A2 receptor antibody, which takes time to come back, and if the patient doesn't fit that epidemiology, you have to biopsy. And the biopsy results, what they're going to do is they're going to do light microscopy, electron microscopy, and immunofluorescence. And this is how you can remember nephrotic syndrome. It's the alphabet soup in a way. MN is 2 letters, membranous nephropathy, more likely to be primary from phospholipase A2 receptor antibody. Then add 1 more letter. Now you're dealing with minimal change disease. Add 1 more letter, focal segmental glomerular sclerosis. So we talked about membranous nephropathy, minimal change disease, focal segmental glomerular sclerosis. This is another one where the secondary causes of it doesn't cause hypoalbuminemia. The secondary causes of FSGS generally don't cause hypoalbuminemia. So what I can tell you is I don't think this is due to diabetes. On the biopsy, the diabetes has a specific pathology, which I'm not going to discuss. But with electron microscopy, light microscopy, and immunofluorescence, you can really make progress as to whether you're dealing with membranous nephropathy, minimal change disease, focal segmental glomerular sclerosis, and then a few others include AL amyloidosis that has its own particular stain. And diabetes, as we mentioned, it causes a Kimmel nodule on path specimen, which is probably not the case here. So when I think about all the secondary causes, I'm like, what can do it? So AL amyloid can cause autonomic insufficiency, and that can cause orthostatic hypotension and syncope. But it's hard to imagine like Hep B, Hep C, maybe syphilis can cause all sorts of stuff. And she has a new partner. So I think testing her HIV status, testing syphilis makes a lot of sense. And getting that CT PE protocol. Oh, and the last group I forgot, and I always forget this one, is the membranous proliferative glomerular nephritis. And this one is where we have to incorporate the UA, because the UA has white blood cell cast and it has some red cells. So are we dealing with an inflammatory, like glomerulo/interstitial process? Potentially. That's usually in the form of MPGN. MPGN is a beast to tackle, but you would send complements and you would want to see, is it immune complex mediated or not? So Elizabeth, what I'm doing right now, CT scan of the chest with contrast to look for pulmonary embolus as a consequence of nephrotic syndrome. I am going to send the phospholipase A2 receptor antibody. I'm going to consult renal. I need a biopsy. Like, we're going to get a kidney biopsy. I'm going to, based on that, those results, the secondary causes, hep serologies, HIV, syphilis, are the most common things that we would consider. And then there's rare primary causes that I'm not going to talk about, but they exist because I've talked too much. So Mike, to you, Elizabeth.
Okay, I don't want to make my team look bad, but we do not have a CTPE for you because we didn't do it.
You can't make your team look bad. They're probably smarter than me and they didn't want to waste radiation costs, etc. It's much different being in live. So thank you. I'm sure that's the right call.
So for the other labs, all the antibodies were negative. We ordered like a ton that you had listed. All were negative. Her HIV was negative. Her Hep B, Hep C was negative. We did an anti-streptolysin O and DNA B. Those were normal. The only thing that came back positive was she had a reactive RPR and an RPR titer of 1 to 256. And at that point, we kind of realized that she hadn't been tested for syphilis ever before, especially like not even with her prior stroke. So we did do a lumbar puncture on her, which came back with a total protein of 73, a glucose of 59, 3 white blood cells, no red blood cells. She had a non-reactive VDRL and no growth on culture. Based off of these results that we have, we actually did not do a kidney biopsy on her. So yeah, this is like the last little bit, obviously, I have before the diagnosis.
Thank you so much. Wow, what a fascinating case. And I saw Yas smiling. Anytime it's infectious disease, Yas is smiling. So, I think that the syphilis, let's just talk about that serology very briefly. When you're evaluating syphilis, there's a syphilis or treponema specific antibody, and then there's a non-specific treponema antibodies. If you think about it, this is medicine all makes sense. The specific antibodies will stay positive forever. They never go away. They're specific to treponema. They're around forever. And so a lot of labs now, they do the backward testing. We used to do like the RPR first, but the RPR is non-specific, and meaning that you can have positivity in conditions that are not related to syphilis, and it wanes over time. It wanes over time. So this patient, you can look at the titer. The 1 to 256 means that they had a diluted 256 times and it was still positive. So it tells you it's very high titer. So this confirms syphilis. But syphilis exists in it exists in early and late. And then you have to think about primary, secondary, and tertiary. And then you have neurosyphilis that can exist anytime. The primary syphilis is the one that presents with the chancre, and it can be painful or painless, despite what they teach you in medical school. It can have pain. Why can it have pain? Because you might have a co-infection with HSV. Once you have one STI, everyone, look for another STI. Once you have one vitamin deficiency, look for another. Once you have one psychiatric comorbidity, look for another. So it's going to be important to send like the urine gonorrhea, chlamydia. But in any case, we weren't told that she had a chancre. This is a patient you'd go back and examine the GU for sure to make sure there isn't any kind of like ulcers. We weren't told of a rash. That's more consistent with secondary. You can get LFT abnormalities, GI stuff that can be consistent with secondary. So the question is, what kind of syphilis is this? And are we dealing with neurosyphilis? Honestly, I don't think we are, because with neurosyphilis, for the CSF, the protein will be high. Like that's quite sensitive. And this patient's protein was in fact high in the CSF, but the VDRL was negative. Usually that's positive. I don't know the test characteristics. Maybe could it be neurosyphilis? Possibly. I'm interested to learn from Elizabeth. I just don't know the test characteristics of the VDRL. But you guys in the chat, please talk amongst yourself. But can syphilis cause nephrotic syndrome? 100% it can. It can involve the kidney and cause nephrotic syndrome. I would imagine that's more in the secondary bucket. So maybe this is secondary plus something neuro. The thing you have to be cautious about here is that when you treat this patient, they may have an inflammatory reaction known as a Jerich-Heighsheimer reaction because of the spirochetes dying off. So Elizabeth, it seemed like you guys avoided the kidney biopsy because you had a good explanation for the nephrotic syndrome. I'm really curious, how were you guys tying in the syncope? Was it through syphilis within the CNS?
To be honest with you, we like pretty much labeled it as vasovagal sympathy because it was hot outside.
I love it. I love it because
We
that's a much better explanation. She was having those symptoms, right? Like she was feeling a little warm and
yeah.
she had the prodrome. We said it. You remember in that first call, we were like, it's either cardiogenic or I
Yeah.
like that. I buy it. So then
Yeah.
dealing with syphilis and nephrotic syndrome.
Yeah, I mean, because we had the syncope workup done like while she was still in the ED basically, and we almost like sent her home until we saw the massive proteinuria, and we were like, oh wow, we should look at this. Yeah, so as far as for the proteinuria, so we did diagnose her with acute nephrotic syndrome due to suspected membranous nephropathy from secondary syphilis. So we consulted with ID a lot about this, and they basically like came to the conclusion that because the syphilis was affecting her kidneys, that made it secondary, but the CSF findings weren't concerning for neurosyphilis. They were thinking the elevated protein was most likely because of her prior stroke, and it just was elevated from that. Yeah. We ended up treating her with a one-time dose of penicillin G IM. She did have the reported amoxicillin allergy, which we did a penicillin challenge, and she had no reaction. So that's how we treated the syphilis. She did have a concomitant chlamydia infection, so we did test her for other STIs at that time. She was sent home with a course of doxycycline. And I will add, so she was seen for follow-up recently in September, was asymptomatic, and her creatinine had come down to 0.9 with a GFR of 78, and her RPR titer was down to 1 to 32. It was cool.
You know what I love that you did here, and I love it so much, is that you found an explanation for everything. You're like, the protein is high in the CSF. That could be neurosyphilis. Hey, but she had the prior stroke. I didn't even think of that. The syncope, it was hot outside. Vasovagal was it's probably going to be the more likely cause of syncope than everything else. And that was the explanation of the syncope. But then she had the lower extremity edema, and the labs showed this abnormal creatinine, abnormal albumin. So then all of a sudden, the problem we were solving wasn't the problem that the patient came to the hospital with. The patient came in the hospital with loss of consciousness, but we discovered nephrotic syndrome, which made us then discover syphilis and chlamydia. And I'm so glad she had a great, outcome and cure. And absolutely, membranous nephropathy makes a lot of sense. And it's the acquired causes. That's what it boils down to. Very simple. I'm excited for Mario, our friend and colleague, to distill the teaching points and make me sound much smarter than I was during the past hour. Mario, help me, my friend.
Hi, everyone. Thank you for this amazing discussion. I think sometimes we're accustomed to to solving only one problem, but in this case, we were presented with two problems. So this was a very interesting discussion. We started with a transient loss of consciousness, which we have learned we can organize into four buckets: syncope, seizure, strategic stroke, which usually is a posterior circulation TIA, and also low sugar in hypoglycemia. Things that favor seizure, as Reza told us, are intra-event manifestations like convulsions, urinary or bowel incontinence, and also post-event manifestations like post-ictal confusion and tongue lacerations. So in terms to approach to a syncopal episode, we have to think on the core issues, which are the cardiogenic, orthostatic, and neurogenic or reflex etiologies. In talking about neurogenic or reflex, we can further talk about vasovagal, situational, and carotid sinus hypersensitivity as the three different buckets. Orthostasis, you have to remember that it's defined as a decrease in a systolic blood pressure of 20 or the diastolic of 10 after 1 or 3 or 5 minutes of standing up. And the buckets can be organized into hypovolemia and dysautonomia. And lastly, but we have to also remember that cardiogenic can be organized into pump or structural issues and arrhythmogenic causes of syncope. We talked about a little bit different, because of the murmur of this patient, we talked about possible structural causes, and Reza reminded us that even though the murmur of aortic stenosis and hypertrophic obstructive cardiomyopathy can sound similar, HOCM is characterized by a dynamic LVOT obstruction. So when there is a reduced left ventricular preload, the murmur is going to increase in intensity, which is the opposite that happens in aortic stenosis. So that's one pearl for the physical exam. But after that, we were faced with the finding of a nephrotic range proteinuria. And Reza gave us a great talk about everything concerning nephrotic syndrome, which included the diagnostic criteria, which include nephrotic range proteinuria, hypovolemia, peripheral edema, and you can add to that hyperlipidemia. We also talked about the complications of nephrotic syndrome, which include thrombosis, venous thromboembolism caused by loss of antithrombotic proteins like antithrombin 3. And we also learned that the risk of thrombosis is proportional to the degree of hypoalbuminemia. And it is also described that there are certain etiologies of nephrotic syndrome that have an increased risk like membranous nephropathy and minimal change disease. We also learned that these patients also have increased risk for humoral deficiencies, so increased risk for encapsulated organisms. And afterwards, we talked about the different causes, which included primary versus secondary, primary being minimal change disease, membranous nephropathy, usually with a PLA2 receptor positivity, and FSGS. But also, we know that there are secondary diseases which can present with these primary histologic patterns. So, for example, in minimal change disease, Hodgkin's lymphoma can cause as a secondary cause. In membranous nephropathy, all the viruses, solid malignancies, and also very importantly, syphilis can cause membranous nephropathy. And so after that, we were faced with a positive treponemal test for syphilis. So Reza also gave us a complete class about syphilis. We talked about the different diagnostic algorithms, which usually was like the classic one where you start with a non-treponemal, which is non-specific to a treponemal, and now the reverse algorithm where we start with a treponemal and then with a non-treponemal as a preferred algorithm. And importantly, the treponemal tests remain positive during the life course of the patients. On the other hand, the non-treponemal tests do not, and therefore they can be helpful in monitoring the response to treatment. And in this case, it was of particular interest talking about the renal manifestations of secondary syphilis, which can range from a transient proteinuria to a nephrotic syndrome, which usually has a membranous nephropathy histologic pattern, and also it can cause an acute glomerulonephritis with acute kidney injury. All of three of these manifestations, which are characterized by a good response after anti-Treponema pallidum treatment. So thank you again for joining in. It was a great discussion. Thanks for Reza for the great teaching.
I have to say, Mario, you made me sound much smarter than I look. Just look at the board. There's so many more teaching points. So thank you for that stellar job in teaching, and really appreciate it. Mariana, thank you for scribing. Elizabeth, I want you to sign us out, but maybe just tell us what your main takeaway, like tell us anything and say goodbye to all of us. Sign us out.
Yeah, I think my main takeaways were, you never know what problems someone's actually going to have based on the chief complaint. We tried to make a connection, and we were like, you know what, maybe there really isn't one. Maybe it was just incidental. And I thought it was really cool that syphilis is a reversible cause of nephrotic syndrome. So it was cool to see her do well afterwards. So yeah. Thanks so much.